Hi everyone, we're going to talk about part 2 of dermatology, and some pictures that I'm showing you here are for some herpes simplex 1 and herpes simplex 2 pictures, and you can look at those further. Herpes simplex 1 was typically thought to be just an oral infection, and herpes simplex 2 typically genital infections, but with an increase in oral genital sex, the reverse is now can be seen in both areas. The majority of these infections are subclinical and asymptomatic and can only be detected by elevated IgG titers. So for the care of these patients, or what is typically seen for signs and symptoms, the symptoms occur usually in 2 to 21 days after exposure. Before the onset of the lesions, you may see tenderness, pain, mild paresthesia, or burning at the site. You could have headaches, fever, muscle aches, localized pain, and tender lymphadenopathy. And then several days later, you can have some group vesicles on an erythematous base, followed by ulcers that crust over. In our elderly patients, they can have a reactivation of the virus that can be extensive. The lesions in the mouth can be difficult to eat and compromise nutritional status. And both of the herpes simplex viruses can cause encephalitis, so if any patient presents with an altered level of consciousness, changes in personalities, fever, or seizures, this needs to be further evaluated. For the management of these conditions, there is no cure. Recurrences tend to be milder and shorter than the initial infection. The goal of treatment is to be symptomatic and supportive. The treatment of genital herpes requires an oral antiviral, and you can find a list of those on page 206. Subsequent management of genital lesions will require treatment and may compromise suppressive medications, and this would be for the patient that experiences 6 or more recurrent episodes of genital herpes per year. Rosacea is a chronic progressive skin disorder of middle-aged to older adults that resembles acne. It has flare-ups that include erythema to the central face. You can have reddened papules and pustules and connective tissue hyperplasia. Some signs and symptoms include persistent burning and itching or stinging. You can have it in the eye area, and your forehead, cheek, nose, and chin can typically take on a flush or a blush type of appearance to it, as this picture indicates. The diagnosis is made on a physical exam. So for the management of rosacea, it's important to avoid triggers that may cause it. Topical treatments are the basis of therapy, and oral antibiotics should only be used for outbreaks. Steroids should be avoided as well, as they may worsen the condition. Some other therapies include electrocautery and intense pulsed light, which would be provided by a specialist. Atopic dermatitis, is also known as eczema, is a descriptive term for a group of skin issues that are characterized by itching, inflammation, and whose cause is unknown. These patients can sometimes have a history of asthma or allergic rhinitis. Their skin becomes excoriated, reddened, and have maculopapular lesions, and later the rash is crusty, scaly, and thickened, as you can see by the picture here on this slide. The goal of eczema is to control the signs and symptoms because no cure exists. The conditions that cause the issue need to be eliminated. So if you have wet skin, it needs to be dried. If you have a dry skin, it needs to be hydrated. And if you have inflamed skin, then it needs to be treated with a corticosteroid. The goals are to decrease itching, prevent secondary infection, and educate the patient so that they can control the disease themselves. Some good mild emollients that are important for the skin include your Aquaphors, your Eucerin, and your Keralac. Next, let's talk about some psoriasis. This is a relapsing disorder of keratin synthesis, meaning that raised red papules and plaques are covered with silver white scales that usually are found in the elbows, the knees, and the scalp. It can occur preceding a strep throat infection, and these plaques and scales are not easily removed and may bleed when if you attempt to remove them or pick at them. Management includes emollient creams, keralytic agents, topical corticosteroids, some topical tar, athrolin, these other inhibitors, and then UV therapy. As with a lot of these skin conditions, the goal is to control the disease. Um, you want to control and decrease the epidermal proliferation and the dermal inflammation with steroids and immunomodulatory agents. And on page 233, you can find different potencies of corticosteroids. And so for those patients with severe incapacitating disease, such as arthritic psoriasis, a referral to an expert, such as a dermatologist or rheumatologist who regularly sees these patients, is important, so they could be evaluated for some antimitotic agents such as methotrexate or cyclosporin. And we talked about that. Um, some benign and premalignant skin lesions include seborrheic keratosis, which are benign, warty appearing growths, and you treat these with liquid nitrogen or mechanically remove. And you can see here in the picture of this person's back what they look like. Premalignant actinic keratosis are rough or scaly rashes that progress in years to a squamous cell, and topical therapy or cryosurgery is used in the treatment of them. Something that we do need to be always aware of is malignant melanomas, and you need to teach your patients about the ABCDE mnemonic, A being asymmetry, B being border irregularity, C color changes or multiple colors, D diameter greater than 6 millimeters, and E elevation or an evolving lesion. Typically, these are large moles on a sun-exposed area that has changed in appearance, and these must be biopsied for anything suspicious. Some other non-melanoma skin cancers can be seen in chronic accumulated sun-exposed areas, more common in men than women. Basal cell carcinomas are 75% of all skin cancers, and you can see in this picture it's more as a reddened sore. It may scab over, the scab will fall off, and it's something that's often described as non-healing. A squamous cell carcinoma can be more dangerous, faster rate of growth, and tends to metastasize. This compromises 20% of all skin cancers, and you can see as it's more exterior, almost like an appendage and scaly lesion there. So for your non-melanoma skin cancer management, you could have, for treatment of these, you could have a simple excision under local anesthesia. You can have some cryosurgery, laser surgery, Mohs microsurgery. You might need lymph node dissection, possibly chemotherapy, and topical therapies. So that is the end of part 2 of chapter 7. And as we mentioned in the beginning, I highly encourage you to find a dermatology book that you like that has lots of pictures and pearls on how to manage different skin conditions and keep it with you in practice. It will be very beneficial as you get started in primary care. Thank you very much.